Okay, I know y'all have studied chest tubes in level 1, but just to refresh, chest tubes are inserted after any kind of trauma or anything, and their main goal is to remove air or fluid from the thoracic cavity that might be compressing the lungs. Our whole goal is chest re-expansion, okay? Just to re-expand those lungs, re-expand that cavity, and allow for healthy breathing. A catheter is left in place in the pleural space just to drain out whatever it is, air or fluid, blood, whatever it might be. They're used with lobectomies, wedge resections, trauma, segmental resections. All of those are talking about surgery in the lungs or trauma in the chest cavity. They're not necessary with complete pneumonectomies because there's no lung that needs to re-expand, and that's something to remember as well. So if you have like a partial lung surgery where they remove like a wedge or a lobe, or just a portion of the lung, or if you have trauma to that area or whatever, yeah, the chest tube is doing its job by re-expanding the rest of that lung and allowing for as much movement and everything of that lung as possible. If they take out the entire lung, we don't need to re-expand anything, right? Right, okay. So sometimes they might insert 2 tubes, especially if it's a very large pneumothorax or something, and they'll put those anterior and posterior. They secure the tubes from the chest tubes into a water seal chamber, and that causes the air or the fluid just to be drawn into that chamber. If there's a break in the system, like a loose or disconnected tube, and air enters into that system, then that can cause a larger pneumothorax to occur, and eventually the lung will just collapse. Here's a picture of the chest tube, and I hope y'all remember how to care for these. But the water seal chambers, they fluctuate initially with each respiration. It might stop happening if the lungs fully re-expand, if the chest tube is clogged, or if there's wall suction malfunctioning, if there's kinks in the tubing or loops in the tubing. If the chest tube is clogged, you can gently milk it, and that's not the same thing as stripping. Here's a picture of stripping where they hold it and then they pull. Milking is very different, okay? If you strip a chest tube, you could eventually pull it out, okay? And then we could cause a pneumothorax. Don't do that. Milking the chest tube is just like clamping your hands over it. Don't pull as you do that. Just clamp your hands over it, okay? And that breaks up whatever has been clogged in there, and hopefully it'll then drain out. Bubbling in the water seal, you want to check it out. There could be like small intermittent bubbles, but if it's like blah, 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 like an aquarium, that's not normal. You want to make sure that everything is tightly sealed and functioning the way it needs to be. Bloody drainage is normal depending on what's going on with that patient. Now, if there wasn't bloody drainage initially, and then all of a sudden there's red or copious amounts of blood, that is not normal. That is something we then need to then check out. The tubing needs to remain patent, which means cleared of any clogs or kinks or anything. The lungs cannot re-expand if the tubing becomes kinked or clogged. As a result, eventually the heart and the great vessels can start to shift to the other side, which is that mediastinal shift, which can eventually cause cardiovascular collapse and even death in your patient. If there's a leak or a break in the system, clamp the chest tube immediately and then just call the doctor. Don't try to fix it yourself unless it's an obvious problem, but clamp it, call the doctor, okay? To change a full canister, the way that you do that is with 2 nurses. You put a clamp on the catheter that's close to the patient's chest before you remove the stopper, and then you can change out the canister. But don't ever try to do this by yourself, ever. It's very important when you're transporting a patient with a chest tube to place the drainage bag below the chest level of the patient. If it's above the chest level, the drainage will not take place, and you actually can cause backflow of whatever is in the tubing at that time. Don't clamp the tubing during transport either. It needs to remain open all the time. The only time you clamp it is if you're changing the canister. To remove a chest tube, you want to medicate the patient before you do so. And this is not something you will do in clinical, just to remind you of this. This is something that once you get out, you get licensed and you're in practice. If your facility allows LVNs to remove chest tubes, then you can do this. But you want to make sure you pre-medicate them with pain medicine because they are going to be in pain when you do this. You want to instruct the patient to perform a gentle Valsalva maneuver, which means just tell them to bear down like they're going to have a bowel movement, but just very gently. Clamp the tubing and then just very quickly remove it. As you're very quickly removing it, you want to simultaneously apply a small bandage that has Vaseline gauze on one side. You put the side that has the Vaseline directly against the chest, creates a tight seal, and then you want to put a dry 4x4 right on top of that and use a non-porous tape, which means a tape that cannot be breathed through. You don't want any air entering into the incision site where the chest tube was placed, okay? You want to do this only if instructed or ordered to do so. If the chest tube accidentally falls out, the patient needs to be aware that they need to immediately put pressure on that site and call somebody and say it's an emergency. The same way that you bandage up a chest tube when you intentionally remove it is the same way that you bandage it up when it's accidentally removed. So when a patient has a chest tube, you want to turn them every 2 hours just to promote drainage and proper breathing. You want to assess their lung sounds very regularly. I do that every single time I go in that patient's room. Listen to the depth, to the rate, to the rhythm, to their breath sounds, everything. Check their O2 stats very regularly as well to make sure that the lung is re-expanding and isn't experiencing any further collapse. And you can tell that because they'll have declining O2 stats if the lung is not re-expanding. Check their vital signs regularly as well. You want to mark on the canister every shift how much has come out during that shift. And the way that you document I's and O's from a chest tube, or just the O's, you're not putting anything in, just coming out, is you look at the mark from the previous shift, you look at your mark, and whatever the number was from the previous shift, you subtract your number, okay, and then whatever the answer is, that's how much has come out. You want to document the drainage amount, the color, consistency, everything, and then monitor for signs or symptoms of crepitus, and that is letting you know what crepitus is. It's like that crackly sound when you push on the chest and when you listen. That is letting you know that there might have been a break in the system and there's air that is entering into the chest, and that is not good. You always want to check your equipment. Make sure the tubing, the suction, the water seal, everything is functioning great. You want to immediately report if there's excessive drainage, if they're having difficulty breathing, if they have a fever, if there's pain anywhere in the body, or if they have any cyanosis anywhere, because that is signaling to you that they're not getting proper perfusion. Okay, here's the questions. The last one. Pause the video. Okay, here are the answers. Check yourself. If you don't understand why those are the answers, then make sure you look it up, and you can ask questions if you need to. Okay, I will see you later.